Good morning, everybody, and almost afternoon. I'm Rachel Rivachet. I am a professor here at UT. For those of you who I haven't met, I teach contracts, family law, and healthcare finance and foreign. And I am delighted to welcome you to this project as a faculty lead for the Reproductive Justice Defense Project. And we have a fantastic program for you. So let me get introductions out of the way so we can dive right in. We are really honored to welcome Professor Kim Mutcherson, who is the Dean Emeritus at Rutgers University Camden. Is a scholar who researches in reproductive justice, ART, family law, and abortion law. We are delighted to welcome Dr. Mardy here. She is a physician and expert in maternal fetal medicine and genetic specialist. She is an assistant professor at the Dell Medical School here at UT in the Department of Women's Health. And their conversation will be moderated by our own Blake Rogat, who is the director of the Reproductive Justice Defense Project, the Sissy Farenthold Reproductive Justice Defense Project, current legal director of Jane's Due Process, and former legal counsel to NARAL, now known as AVAL. So without further ado, why don't I welcome Kim to kick us off.
Right. All right. So I am super excited to be here with all of you today and really excited for our conversation after I am done spewing information at you. And I'm also just super great. These are the wrong notes. That is not going to be helpful. Let's try this again. Better. I did the health law colloquium last night, and so these are the notes for that. Okay. Thanks to Blake for inviting me to speak to all of you today, and I'm super grateful for the work that he and Rachel are doing here. So I am not a researcher in the sense of doing qualitative research. That is not what I do very much, but I have ended up doing it in this context, and I want to give you a little sense of why I am doing that work and how I came to do that work. So as a starting point, it's just a huge step out of my comfort zone, but I'm super excited about it. And obviously, in terms of background and how I got here, post-Dobbs, the law of abortion in this country has been thrown into deep, deep disarray. And there were lots of things happening as soon as Dobbs took place. Really rapid changes in the law, enormous amounts of instability, and also it became very clear that there were folks who were not getting care, who were being denied care, whose care was being delayed, even though prior to Dobbs, they would have gotten the abortions that they needed or the miscarriage care that they needed without those kinds of delays. And some doctors were starting to raise concerns about the advice that they were getting from lawyers that they work with and the people to whom they turn to say, okay, what does this mean, right? What does the statute in this particular state mean? And it felt like lawyers were playing this very pernicious role in the disarray that was happening post-Dobbs. And then other research started coming out where lots of doctors were being interviewed and there were qualitative research projects that were happening. And again, these doctors were saying, you know, we know who the problem is here, right? And the problem is lawyers who are inserting themselves and who are telling us that we can't provide the care that we think is appropriate care. And so even as a law professor and lawyer, I am as willing as anybody else to blame lawyers, right? And so the first thought was, all right, the lawyers need to get it together, and they are just the real problem here. But then as I started really thinking about it, I thought, it's got to be more complicated than that, right? It can't just be that there are a bunch of lawyers who are running into operating rooms and saying, stop, you cannot perform that abortion. So I wanted to understand that better. And so I dragged a really good friend of mine who does do qualitative research and who's a colleague of mine at Rutgers Law School. I dragged him into the project because he's got that background. And though he doesn't do the kind of work that I do, he's an insurance and risk person. So he was also interested in how insurance might be playing a role and how lawyers are interpreting these statutes. So we said, we're going to do it. We're going to do this research project. We got our IRB approval and all that good stuff, and started talking to people who are doing this work. Our initial plan was just to focus on restrictive states because those were sort of the most interesting to us, and those were the places where we knew that people weren't getting the care that they needed. But then as time went on and we started seeing other sorts of trends, we decided we wanted to also talk to people in surge states. So, what's happening when people are crossing borders in order to get abortion care, and how are folks trying to deal with questions of, for instance, a minor who comes across state lines and gets an abortion, all those sorts of questions. So we wanted to think about that. And then we also wanted to think about doctors who are doing lots of telehealth across state lines. And we know we've seen a couple of people indicted so far. Louisiana has done an indictment. Texas has a lawsuit of physicians in New York. And obviously, the most important thing you say to those physicians is don't go to Louisiana because you're under indictment there. But trying to think about, what does that look like, and does it impact the ways that people are interpreting state statutes and providing abortion care? So the core questions basically that we were thinking about, right, those are the points I just made. The core questions that we were thinking about in terms of the role of the lawyer is, what do we think, right? What should the role of a lawyer be in these situations? What role are lawyers actually playing? What is it in the law that's making the job of lawyers, hospital lawyers, difficult in these circumstances? And what could make their job easier? So our overarching idea, obviously, is that the role of a hospital lawyer is not to do medicine. That's not what any of us, some people are JD-MDs, most of us are not. So the goal is not to do medicine, but it is to interpret the law so that doctors can stay on the right side of it. And the problem, of course, with that is that the laws themselves are not particularly clear, which is not accidental. And so there are lots of ways in which these laws can be interpreted differently. And I'll just give you a couple of quick examples. This one is from North Carolina. It has no explicit life or health exception in it, but it does allow for removal of a dead fetus or an ectopic pregnancy. It says that physicians can use their judgment about what's an emergency, because there is an emergency exception. So maybe that is what gets you to a life or health exception. And they also allow you to perform abortions where there's a life-limiting fetal anomaly. You all are law students. We could have 20 different definitions of what a life-limiting fetal anomaly is, right, if we wanted to. So that's just one example. The other example that I typically use is Texas, because lots of problematic things come out of Texas when it comes to abortion. So I'm not going to read through all of these, but I want to just give you a sense, right? So the first part of it says that physicians can use, or healthcare providers can use, their reasonable medical judgment, and then it tells you what that means. So you would think, well, that's great, because then what it's saying to doctors is, you're a doctor, be a doctor. Do what's the standard of care, do what's within your reasonable medical judgment. And yet there's still lots of concern about what people can do and when they can do it. Texas is also a state that has had litigation and has also had changes to their statute over time. Again, using this language of reasonable medical judgment, but then they have started adding things like, for instance, you don't have to be at death's door before an abortion gets performed. You don't have to already be losing a particular bodily function before you can perform an abortion. So sort of expanding the language in a way that is meant to make it easier for lawyers to do their jobs, which means that potentially it's going to be easier for doctors to do their job as well. And then the last piece that I want to go up here. And then or second to last piece that I should say, is also trying to kind of figure out, obviously, the circumstances in which abortions are allowed, but also in which abortions are not allowed. Part of what they're trying to do in this section is provide some sort of leeway for people who are providing care that isn't necessarily even abortion care, right? So if you're providing care, for instance, cancer care to somebody who happens to be pregnant, and there's a loss that's associated with that, that is not an abortion. You're not going to go to prison for that. You're not going to lose your medical license for that. And then, as I said, they do a very specific carve out for an ectopic pregnancy and for a fetus where there's already no fetal heartbeat, there's no fetal cardiac activity. So if you're a lawyer, there's lots of things that you're trying to figure out here, right? So first of all, you're reading all these sections of the statute in conjunction with each other, right? You can't just read them each by themselves. You can't try to parse them in isolation. We've seen a couple of indictments that really seem targeted at shield law, so it's hard to know whether there are going to be prosecutions, and if so, what those prosecutions are going to look like. Some prosecutors have said very explicitly, I'm never going to go after a doctor for performing an abortion. Most have not. Some prosecutors who said that have lost their jobs because they said that, so don't say it publicly. And then we've also gotten some clarifying state court cases, but still lots of confusion and lots of ongoing litigation. So our goal has been to try to understand the landscape. So most basic question that we ask people is, what are you doing, right? And how did you decide what you were going to do? Did you create a policy? Who was involved in making that policy? Did you create a list of conditions that people could use if they wanted to perform an abortion? If people have questions, who do they come to and how do they get access to answers to those questions? We also wanted to know how these lawyers perceive their role in enforcing and interpreting exceptions, right? As a hospital lawyer, how do you think about what you do in that setting? How are lawyers cooperating with each other or not across institutions in the same state or across states? What organizations, if any, are providing space for lawyers to discuss their work? How conservative are folks being, and what factors are leading people to be more or less conservative in how they're interpreting statutes? Has the facility altered their standard of care? Most lawyers who are being careful should never say to me that they have actually altered the standard of care, because that's going to raise issues as well, but some have said that. What would make lawyers bolder in terms of the latitude that they give to their physicians? What are the internal structures that they're creating? All these others. And also, does institutional structure impact decision-making? So public hospitals versus private hospitals, Catholic versus non-religious, academic versus not academic, rural hospitals versus urban hospitals, all these sorts of questions. So here's some of what we are hearing so far. Let me skip through all of this because I want to make sure we have time to talk. All right, so some of what we are hearing so far. And the caveat that I will give you here is that we have not been able to talk to a lot of people. One of the hardest things about this research, shocking, is that a lot of people do not want to talk to us. Even some of the people who've been willing to talk to us have not been willing to have us record those conversations, even though we'll be destroying those conversations eventually. So people are nervous, and they're really nervous, and they have reasons to be nervous. So I don't judge them for that, but it makes it hard to do the research. So first thing is that they're obviously working within an atmosphere of fear. As I said, it's been really hard to get people to talk, and it's been really difficult to get people to share materials with us. So some places do have written protocols. They will not send them to us. Some places have lists of particular conditions where they say, if you get a patient with this condition, you're totally fine, go ahead and perform the abortion. They won't give us lists of those conditions. So they're keeping that stuff very, very close to the vest. Also, that for some folks, that abortion is sort of a topic of new concern, which you think wouldn't be the case because I'm talking mostly to people who are in restrictive states. And the reason why it's become a topic of new concern is that when there were lots of clinics in the state, if you didn't want to perform an abortion, you said, go down the street to Planned Parenthood or go down the street to whoever else is performing abortions here. Now those places are closed. So that sort of safety valve that folks had doesn't exist anymore. So they really have to think about, if we're going to provide this care, how are we going to provide this care? Because if we don't provide it, either people aren't going to get access to it at all, or they're going to have to travel miles and miles. They might have to get on a plane. I actually drive for a practical support network where I live in New Jersey, which is right outside of where I live, right outside of Philadelphia. And I had a woman from Texas who I picked up from the airport in Philadelphia who was getting a second trimester abortion in Philadelphia, right? That's a big thing to ask people to do. And so it's really interesting to see how some people have been saying things to me like, normally these are not abortions necessarily that we would have been performing, but we're it now. And I feel a responsibility as part of my institution to make sure that where it is possible to provide care, we are providing that care. And so what they're saying to us, many of them, is that their job is to facilitate the care that patients need, that their focus is on medicine and not law. Doesn't mean that they're interested in pushing the envelope necessarily, but they do want to make sure that they can do, that providers can do what they believe is necessary. Criminal penalties have really upped the ante. So before a lot of these statutes, the thing that healthcare providers were potentially most afraid of was a medical malpractice claim or potentially a complaint to the licensing board and somebody trying to go after your medical license, both of which are scary things, neither of which is as scary, I think, as going to prison for double digits, right? And so suddenly the hospitals had to really think about, all right, how do we get our lawyers to feel confident that they can provide this care? And what we've seen from some hospitals is one in particular, they actually gave each of their physicians an indemnity letter that said, if you get prosecuted, here are all the things that we are going to do for you, as long as you are exercising your reasonable medical judgment, right? We're going to make sure that you get, that you have counsel, because obviously you don't want hospital counsel representing you because they are not criminal defense lawyers. We're going to help you keep your license, all of those good things. So that has really changed the calculus, the idea that the penalty is so different here. As I already said, responsibility to communities that they serve, and that the role is to facilitate patient care. One of the things, I'm a torts professor in addition to all the other things that I teach, so I was like, MedMal is going to be all over this. And one of the things that I was really surprised by is how little the lawyers were concerned about medical malpractice. And there are a few reasons for that. One reason is that if you think about restrictive abortion states, you are also talking about states that were very early on in tort reform. And so the idea that, you know, there's a huge cap or a low cap on pain and suffering damages, that it's going to be hard to find a lawyer who's going to take those cases because there's not enough money in the case, or some of the places that we've talked to, actually almost all the places that we've talked to, they're all self-insured. And so they feel really confident that they are going to be, if they get sued, either they're going to win or that they know what the cap is, right? And they're not worried about what happens there. What's interesting is that it's not clear to me that physicians feel the same way, right? I think they are still concerned about medical malpractice, but the lawyers are not so much. Lots of what has been done is, as I said, supporting people if they have concerns about prosecution and making sure that they feel like they're not going to be abandoned if they are exercising their reasonable medical judgment. But it's not just the providers, because part of the other fear, and we were just talking about this, is that people are going to narc on you in your facility. So you're performing an abortion that you are confident you're able to perform, but there's a nurse down the hallway who suddenly calls the local prosecutor and says, I think an abortion happened here that shouldn't have happened. So creating this very problematic atmosphere of fear, frankly, within the facility. So because folks are saying, listen, we want to protect you, we want to make sure that you can provide the care that you need to provide, there's a real emphasis on documentation. What is going to go into the medical record? And most of what we're talking about is electronic medical records at this point. So what we're seeing from some facilities is they actually are creating phrases within, a lot of people use Epic, they're creating phrases so that they can make sure that every single time somebody performs an abortion, they are using language from the statute to explain why they are are performing that abortion. They're making sure that people are using the right insurance codes even, because if you use the wrong insurance code, that may imply that you performed an abortion that you shouldn't have been performing. So lots of emphasis on what is going to go into the medical record and being very precise about what you're doing, why you're doing it, and why you did it when you did it. So this is another place where I think we have seen distinctions between doctors and lawyers. So lawyers, and again, law students in the room, vagueness can often be our friend, right? Because if it's vague, then we can start to interpret it and we can say, well, of course this fits in because blah, 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 blah. And I'm going to give you 10 different arguments about why this particular abortion fits in. So our folks have not necessarily been interested in, let's have a full list of everything that, every condition that is acceptable to perform an abortion. That's not necessarily true of physicians, right? There are certainly physicians who think I'm better off if I'm performing an abortion and there's a list somewhere, whether it's a list in our hospital or it's a list in the legislature that says, okay, this is a premature rupture of membranes, we're good. Right. And so they actually want to have that kind of specificity. But that, again, can be a problem. Court cases have also been helpful in this regard. So for instance, Texas had the state Supreme Court decision. That was the first thing that said to folks, you don't have to send somebody out to the parking lot and let her bleed for another couple of hours before you perform the abortion, which was huge for that to happen in Texas and then to have it actually enshrined in the statute. People like to not be the standout. People like to know that other hospitals in their area are doing the same thing that they are doing. They don't want to be outliers. What's been difficult, though, is that people also aren't necessarily talking to each other. Again, because people are nervous, they don't necessarily want to share information. And so people do sort of feel like there are these islands, even though they know there are other abortions that are taking place in their state, but they aren't able to talk to those people and they aren't really able to coordinate. And that has really been a problem. And then another piece of the puzzle that I literally didn't occur to me at all, and this is just a sign of how deeply lawyer-centric I am. I had one lawyer say at one point, some of these folks who are denying care, they're probably not talking to a lawyer at all. And I was like, right? And he was like, somebody shows up at a rural hospital in the middle of the night and they're miscarrying. That's not a person who necessarily has a lawyer on speed dial and says, let me, call Joe Schmo or Jill Schmo and figure out whether we can perform this abortion. And I was like, yeah, everybody doesn't talk to lawyers. Okay, fine. Which then creates a whole other wrinkle, right? Because we're making this assumption that lawyers are somehow playing this incredibly important role in how care gets provided or doesn't get provided, when in fact, maybe some people aren't talking to lawyers at all and aren't concerned about what lawyers say and are really just doing what they want to do based on the patients who are coming through their doors. And then another piece that we have found really interesting is the relationship between in-house lawyers and folks who are on staff and people who are outside counsel and folks who are on staff. And the reason why this has been interesting is that when somebody is in your building, you can walk upstairs and you can go to their office, you see them all the time, you've had all sorts of exchanges with them. You don't just talk to them when something difficult is going on. You may talk to them in a lot of other sets of circumstances that folks have a closer relationship to those people and therefore feel like this is a person who understands what I do. This is a person who has my back. And if they tell me that this is the kind of care that we can provide and they give me parameters, I'm going to feel really confident about that. It's not necessarily clear that folks always have those same relationships with lawyers who are outside counsel. Still people obviously who know the law, still people who obviously want to help you to facilitate care, but not necessarily people who are as deeply trusted as folks who are within your institution. So there are still lots of conversations that we're having with people. We just did a an interview a couple of days ago with somebody who was totally different from everybody else who we had talked to, in the way that she talked about creating protocols. She made it very clear that in their facility, the goal was to not have the doctors ever have to come to the lawyers, right? They set up a process. If you have a question, then you should be talking to the chief medical officer, or you should be talking to whoever's the head of your particular division. You shouldn't be running off to lawyers. And on one hand, I thought, yeah, okay, that's great because it's medicine. On the other hand, I thought, yeah, that's brave of you, right? So we'll see how that plays out in the end. So that's the stuff that we're hearing so far. And obviously, we're still trying to have lots of conversations with folks. As I said, the hardest thing has been getting people just to talk to us. Even people who, you know, a doctor says to me, because a lot of what we've been doing now is getting doctors to introduce us to the lawyers at their facilities. And people will say to me, oh, yeah, our lawyer has been fantastic, has been so helpful to us. You know, that person's the reason why we were able to do what we do. That person's definitely going to talk to you. And they introduce me, and then it's like radio silence, right? Never respond to my emails, won't even get on the phone with me I have like a 15-minute spiel that I do to try to get people to do interviews with us, and they won't even talk to us. So, and these are folks who I think should feel really good about what they're doing, because the doctors on their staff like them and think that they're really good lawyers. And yet even those people don't want to talk to me. So it's been a really difficult process. And so that's why whenever I talk about this research, I say to people, if you know anybody, not even necessarily a hospital lawyer, if you know somebody who knows a hospital lawyer, or somebody who knows a hospital lawyer, I'm happy to talk to them. I'm at the 6 degrees of separation point at this juncture. So please feel free to send them my way. And I'm going to stop there so that we can have a conversation.
Dr. Mardy, I wonder if you want to take a minute to respond with your thoughts to that, and then we'll maybe have some questions, or?
Sure. Hi, everybody. Sounds good. Should I sit here? Stand? Doesn't matter. Okay, great. I first wanted to say thank you to you all for coming. We need people to fight for our patients here in Texas. We need doctors to be here in Texas. It is really hard to recruit OBGYNs to Texas. We need people here to treat our patients here. We need lawyers who will defend us, who will help us practice medicine the way that we want to practice medicine. So thank you all for being here. Thank you for caring. Thank you for caring about the women in business. Yeah, I am a maternal fetal medicine doctor, so I don't do abortions early on in pregnancy. I've never have. The main reason that I might be involved in this conversation is I diagnose fetal anomalies, and then without restrictions, I would counsel a patient about her different options, ideally in the hospital that I'm at. Now, when I first started here, SB 8 had passed the week before, so it was not what I was thinking I was going to be stepping into. The best thing about my job is my department and the leadership. Our hospital leadership in my division very much cares about this and is pro-woman and does whatever they can to help defend us. So what they have done working with our legal team in the hospital is allowed us to still talk to patients about the option of termination of pregnancy, and we can physically give them information about where to go. I have a document that has QR codes about websites where they can look up how to go out of state. Obviously, I can't really do anything beyond that legally, but I don't have, there's no gag order. I can, at least that's what our lawyers have told us. So I can tell people about this. So the way that I practice in that sense of telling patients that it's an option and how they can get, they can look up how to get funding, how they can look up how to get access to that. That hasn't changed, luckily. So I'm very grateful that my department all it's coming from the same place, and no one's really, it's not a controversy in my department, which is really nice. So fetal anomalies is the big one, and then maternal complications of pregnancy. So PPROM, so breaking your bag of water, especially before the fetus is viable. The Amanda Zarowski case, I'm sure y'all heard of, that happened a few years ago at our hospital. And unfortunately, she broke her bag of water very early. Usually patients are given the option to have expectant management, give this fetus the best shot, or knowing that there's a very, very tiny risk that A, the fetus is going to survive, and B, that fetus is going to survive without really severe neurodevelopmental problems. We usually give them the option to end the pregnancy and not incur more risk. But with SB8, we couldn't do that in the way that the law was interpreted at the time. We had to wait until this patient got sick enough where it was now a medical emergency. So she became septic, and then finally we could intervene. Luckily, the law has changed, and PPROM early on, we now can offer termination of pregnancy. I work at a Catholic institution, and so there's a whole ethics department conversation that we have to go through and get approval from the local bishop. But we can do that. We can still offer standard of care in that situation. And then the last thing in terms of fetal anomalies that are life-limiting, again, however you define that, if there's a maternal complication that comes up, such as preeclampsia. If you have preeclampsia and you develop a severe feature of this, such as headache or severe range of blood pressures, you start to see some lab abnormalities. Usually we'll try to keep patients pregnant up to a point where we feel like baby's going to do well on the outside. But it's really only for baby's benefit. There is not any benefit to mom at all. So if there is a life-limiting condition and mom develops a complication where we're incurring any more risk to mom, then we then have permission to end the pregnancy in that situation. Any questions? How would you like to move forward?
Yeah, why don't you join us back up here, Professor Mutcherson, and we'll see if anybody has any questions. If not, I've got some thoughts of questions to pursue. Well, yeah, I can put that chair. So, for you, Professor Mutcherson, how do you feel that your qualitative research is? Do you think there's any problem with two things? Perspective that you're getting lawyers who are saying, "Oh yeah, we're providing this great guidance. These are our goals. This is what we're doing," and then from that is different. They're not communicating what they think they are. Mm-hmm. That the doctors are getting a different piece of information or understanding that guidance differently, and you're hearing one side of that story. Mm-hmm. Like, have you talked to physicians who are like, actually, my lawyers are doing a bad job. They won't give me any guidance. They can't tell me I'm protected. Like, I'm just curious about the other side of that.
Yeah. So there are a bunch of studies that folks have done with doctors where the doctors are basically like, our lawyers are garbage, right? Which is fine. That's your opinion. And so, we really wanted to get some of the lawyer perspective, but two things that I think are important in terms of potential bias in our research. One is that the people who are talking to us are people who feel good about what they're doing, right? So we're getting a self-selected group of people. I would very, very much love to talk to somebody who says, I've always hated that our hospital did abortion care. The best thing that ever happened to me was that the law changed, but nobody like that has talked to me so far, and potentially won't ever talk to me. So I think that that's true. And then, I also think, and this is sort of a basic premise of how we've been doing the research, lawyers and doctors don't talk the same language, right? So if you come to me as a physician and you say, I think I need to perform this abortion, can you guarantee that I'm not going to get prosecuted? No. Right? I don't think you will. I think it's highly unlikely we'll represent you if you get prosecuted, all of those things, but I'm not going to tell you with certainty that that's a thing that's not going to happen to you. So if that's the level of advice that you want from me, then we're just not going to get to a good place. So Rick and I were actually talking the other day about going back to some of the facilities and talking to doctors in the facilities where we've talked to the lawyers. thinking about how that might anger some of the lawyers that we're talking to. So we're trying to kind of figure out what would be the best way to do that. But, we do want to understand how what we're being told translates for the physicians and other healthcare providers who are trying to understand the parameters of care.
And Dr. Mardy, how have you experienced the other side of this conversation? I mean, I took from your remarks that you felt the guidance was helpful, was good. I wonder if there was any specific to some of the questions that Professor Mutcherson is asking, the lawyer she's asking, like, what have you done? Did they change policy? Was there a memo sent out? Was there, like, how did you receive any institutional or legal guidance to affect your practice of
Yeah.
medicine?
It's so interesting that you talk about not having a written policy. It makes sense now. This has all been over meetings just within our department, only verbally talked about.
Yeah.
There's nothing written down at all. And now I understand why. I know when the laws first changed that allowed us to treat PPROM that's early on standard of care, I remember being on service and being like, this must have been an email. I just going to pull this up and show everybody that it's okay that I do this. And I was shocked that there was no email. I couldn't find anything on the hospital website. There was nothing at all. And I had to just make a bunch of phone calls and just trust that people knew what they were talking about. At the end of the day, it was, partially putting me and my family's future on the line because I believe that this was the right thing to do for the patient. So taking a risk that if something's wrong, I could go to jail for this, but just believing that I'm doing the right thing. I know people will have my back. And so far, so good. So yeah, I think that makes a lot of sense that there has been nothing written down.
Yeah, and that's a real conservative way to operate, right? When in fact it might be more helpful if something were written down, even if it were broad and not a list. So that's a place where guidance is a little short.
Yeah, and luckily we have a good relationship with our hospital nurses and staff where they trust us if we say that. But it would have been great in some situations to show like, look, you're okay being a part of this. We've been told this is okay. It's written down right here.
Professor Lauren. You're the only hand I saw, so let
Well, it relates to the about feeling like there's a good relationship among doctors and nurses, and it relates to the comment in the findings earlier about concern about sort of trust within the organization and the institution. It got me thinking about. Well, I just think that's a really interesting dynamic, and particularly in thinking about criminal law and from this potential scope of criminal liability. I don't even know whether, the hospital lawyers you're talking to, who probably do not have a criminal law background, even have in mind the need to be thinking about, say, the scope of accomplice liability in the context of an institution and forms of practice that are so collaborative, right? No one person is doing everything that sees any procedure from beginning to end. Everyone's contributing to pieces of it, but presumably all trying to help it along. There's no way to continue to practice medicine, but also sort of silo people in a way that provides layers of protection if criminal allegations arise. And so I'm just interested in how, from either of your perspectives, how that specter of kind of not just individual criminal liability, but like group criminal liability, like the operating room becoming, a little conspiracy factory, like weighs in the culture of the organization.
Absolutely. One of my family planning trained colleagues was fairly new a few years ago, and I think it was a fetal demise, maybe around 18 weeks. So no heartbeat. There's no one can argue that there's an issue here. And even then, there was all this kind of talk behind the scenes about, is this the right thing? Breaking the law? Do we need to report this person from? There's so many members, as you mentioned, there is nursing staff, there are OR techs, there's so many different steps along the way. We are not performing these in a vacuum, where she has decided she's not going to do this anymore because of all of this behind the scenes chatter, even though she knew that she was doing the right thing. So it's definitely impacted what we can offer patients.
I think, I mean, some of the folks who we talked to were very clear that they weren't just talking to doctors, right? They had to talk to staff up and down the chain in order to make sure that people were comfortable and that people were confident. I have not heard of anybody doing indemnity letters beyond physicians, though. So that's sort of interesting now that you have said that. But the other thing that's interesting in abortion care, I mean, abortion care has been exceptionalized for so long. So, a person can say, I'm not gonna be the anesthesiologist for this procedure because my conscience tells me that I can't participate in abortion care. So, facilities have already had procedures in place to allow lots of people to say, I won't do this because I don't believe in it. So that, I think, has really sort of kicked into high gear as a consequence of the changes in law, because now you really don't want to have somebody who feels like they are participating in a procedure when they've already told you they won't do those at all. So I think one thing that's important to just remember about all of this is that abortion has been treated differently for decades, right? And so there's this level of comfort, I think, that we have with that we shouldn't have, and yet that's the way that we operate.
Sorry, over here and then here.
I know you said that you're not seeing a lot of concern over malpractice with the hospital lawyers. Are you seeing any change in malpractice insurance?
No. And again, part of that is because, so my colleague who's the insurance person, I ask all my questions and I'm like, do your boring stuff, right? He doesn't think it's boring, but whatever. The people who what we've sort of learned about hospitals has also just been fascinating, that so many of them are self-insured. And so they are making all the decisions, right? They're not worried about what some external insurer is going to say to them. And insurers can often have significant control over what happens, right? But that's not happening here. So they are allowed to do a lot of internal decision-making about what their concerns are, right? They're not worried that their premiums are going to shift or any of that stuff. So that's been for my colleague, at least, that's been disappointing, because he was sort of hoping that insurance companies would have sort of swooped in and said, all right, how are we doing this? Because we don't want to be paying out these malpractice claims, but they're not involved.
Do you think that's problematic in that it doesn't provide the counterbalance to doctors practicing up to the standard of care because there's no threat on that other side, and there's this giant threat of criminal liability? I mean, that's what's driving kind of some of the poor outcomes we've seen.
Yeah, I mean, there was a period of time, again, as I said, I'm a torts professor as well. And I'm probably still having some of these conversations. I talked to a lot of people who are in activist circles, people who are lawyers, about how it could change the landscape if a couple of if some doctors got sued, right? It changes the calculation, and it changes how hospital lawyers might think about what's happening here. But again, the structure of these, at least the hospitals that we've talked to, is such that, one, they're not scared that they're going to have a big payout. Right? I mean, we've talked to people who, because they're state institutions, there's a cap specifically on them because they're a public hospital. They have that money in hand, so they're not worried about it. But also, as I said, that the lawyers aren't going to take the cases. And so I don't know and I don't even know if it would really change their hospital practices that much. If we did get some lawsuits, I'd like to see it. I'd like to try and see how it plays itself out.
I wouldn't.
Totally fair. But it'd be nice to have a little bit of that counterbalance. But it's not, I don't see it happening anytime soon.
Camille.
Question, I guess, mostly I think for Dr. Mardy about how, if at all, impacted like teaching protocols and what you all are able to teach, how you go about teaching. The law's changing every day and just like the knowledge that you want doctors to have to take. Now, just, I feel like that would really help.
Absolutely. In terms of my bread and butter practice is reading ultrasounds and talking to patients. And we have residents and fellows that are kind of shadowing me and seeing patients. That hasn't changed because I still will counsel exactly like I would where I trained in San Francisco. That doesn't change at all. When I'm on the antepartum service is where it changes, where I have to, the residents, they can't get training in abortion care in Texas. So they travel to Los Angeles if they want to. It's an optional rotation that they can do. There's allegedly a new law out there that might put that at risk. I don't know if that's how true that is or if that's just a rumor. If that goes away, then it's really detrimental. For fetuses who pass away during pregnancy, we can offer either an induction, where we put the mom into labor and she delivers the baby like you would a live baby, or a procedure called a dilation and evacuation, or a D&E. So the residents are not getting the option for a D&E. One, because I work at a Catholic hospital, but it is permeated throughout. So we have faculty that do perform those, they'll just do it at a different site. But now those faculty are moving to Colorado. We have our kind of sister hospital that we tend to send patients to. Again, they've decided they're not going to do that anymore. So that's considered a safer procedure for patients. It's a way lower infection rate. It's a lot quicker. It's just not an option anymore, and the residents aren't seeing that happen. So they get like 1 month of learning how to do that. Even though it's a legal procedure that you should be able to perform and give that option to patients. So it's definitely impacted that. And then the knowing when it's okay to have an early induction of labor, even if we don't think the fetus is going to survive. Reminding residents that it's okay to do this. There's a lot of trepidation. So we had a case conference this morning about a fetus who had anencephaly. So they're missing a part of their skull, and over time the brain tissue erodes. And just having to remind them that if mom breaks her bag of water, it is like, even if this fetus is viable, there is no reason to wait, and having to just reiterate over and over again. It's not like a natural thing that they understand. But I think the biggest impact is the actual abortion training impacts the standard of care that you would give even in a non-abortion setting. So caring for demised fetuses has changed.
Has there been any like difference in guidance from like the name is leaving me now, but like the National Medical Oversight Committee or something?
ACOG, AMA.
I don't know. But
One of those.
yeah, I'm sure there's like a medical national organization that has like customs of like medical practice.
Yeah.
Has there been differences in how they instruct physicians on abortion care due to docs and maybe like state specific care because of the new restrictions?
I know that there's been literature out about how they believe that abortion is healthcare. So in terms of that language, that's out there, but in terms of specific instances, I don't.
No,
think
they're
so.
definitely not doing that. Yeah, ACOG is definitely not doing that. ACOG is involved in some really interesting projects that are about trying to maintain access to abortion care, particularly in emergency room settings where it's has been especially problematic. But you know, one of the sort of underlying issues of all of this is that these statutes are potentially fundamentally changing the standard of medical care, which we don't expect state legislatures to do in any other setting, right? We're not like, when should somebody get a vasectomy? Let's go ask the legislature,
Yeah.
right? So it's a very strange thing to put doctors in a position where they know what they're supposed to do, what they've been trained to do. They've had the conversation with the patient, but then the law doesn't allow them to do that thing, which if it isn't standard of care, this is the other paper that we're probably gonna write. If the law has changed the standard of care, does that mean if you did sue for medical malpractice, the response from the doctor would be, yeah, it's not standard of care, but this is what the law said, and so I couldn't do what was standard of care.
Hold on, let me go back here, Nancy, and then.
So it sounds like there's been a lot of discussion between like clinical departments and lawyers, but has there been, like, what is the dialogue like for the non-clinical departments, like the billing department and finance?
So we haven't had a lot of conversation about that. I mean, it's shown up in these weird places, like, the thing I said about insurance codes, like making sure that that information goes in properly. But that doesn't, and maybe because we haven't asked the questions, but that has not seemed to be a big part of what people are concerned about.
I have no idea.
Yeah.
I think that I didn't even think about billing being an issue, and it makes sense. That's how we get a lot of information, is looking at the billing. It's the easiest way to get it. But I'm not sure what conversations happen.
Nancy.
Yeah, my question was around in talking to people at the places where there is some sort of protocol or guidance on what to do, like who is writing that? Like who is doing that, and how much input do the lawyers actually have versus like actual medical like knowledge? Like, is there a lot of friction in like those protocols actually being written?
Yeah. So I will say again that I am talking to people who are like, we need to facilitate care. We're not doctors. And so for them, all of those protocols start with the medical staff, right? Often with the chief medical officer. Sometimes it'll be the CMO, and it'll be, the chief of OBGYN, MFM doctors. What's interesting is that the maternal fetal medicine docs and the OBGYNs aren't always on the same page, right? So one of the things that I've also heard lawyers say, and they're getting it from the doctors in the facilities, is, well, yeah, we used to do abortions for, fetal anomaly. No, they won't say abortions. We used to do these for, fetal anomalies or for X, Y, or Z, but those weren't really abortions. Those didn't count, right? And whereas an OB would be like, what do you think you just did? You terminated a pregnancy. And so, it's depending on who is in the room for those conversations, but usually it's going to be the chief medical officer, it's going to be the head of the different divisions that are relevant, including the emergency department, because when somebody shows up in middle of the miscarriage, we need to figure that out. They decide what the medical protocols are. And then the lawyers will often come in and say, well, this is how we're going to document it. This is how we're going to make sure it shows up in the chart. As you all need to be clear that what you are doing is based on standard of care and your medical judgment. And if that's the case, then we're going to back you up. So it starts with the medicine and then goes to the law.
Thank you.
At least that's what they're telling us.
Any other thoughts or questions? Maybe I'll have one more. Oh, I'm so sorry.
So I'm a healthcare attorney that you haven't talked to, so we'll talk after.
That one.
But, and I think Blake was there when we gave a presentation at the Texas Health Law Fall Conference. And I had maternal fetal medicine specialist and ER Dr. Lauren Fine was with us. And the thing that I want y'all to understand this, because this is your healthcare, that drove, and I've been doing healthcare law since 1991. And I've been involved in emergency room cases since 1991, and before that in hospital administration since 1984. So I've been in hospitals a lot. The thing that freaked me out the most was ectopic pregnancies, okay? Texas law, you go in and you look at chapter 245, look at the definition of abortion, removal of an ectopic pregnancy, not an abortion in Texas. I mean, whether you code it and whatever you did, abortion may be in that, but it's not under Texas law.
However, to hear the doctors in Texas are afraid that it precisely is an ectopic pregnancy, and it's ectopic when they rupture. Do you know what risk that's putting women at to rupture when you have information that might be 90%, 95%? It's ectopic. Let's deal with it. Methotrexate, we could do it medically, or we need to go in and do a procedure. It's not happening. And to hear an ER doctor from San Antonio, Texas, was on duty recently. She basically diagnosed herself, went to her OBGYN. Her OBGYN said, we need to do another HCG test, which is a hormone test to see if the pregnancy level, hormone level is going up. Guess what happened to her? She ruptured before that happened. If she can't protect herself, who of us can? All right? So I want you to understand how important this is. So my reach out on this was, we have a maternal designation system in Texas. Every hospital separately has to have their maternal level of care. They're required to do quality assurance reviews of the cases in the hospital, including the cases that go bad. And I called them and I said, hey guys, you can't force this, but could you suggest that ruptured ectopics get looked at more closely under maternal designations? But it's like the Whisper Network to get something done because of what's going on in our lives. So that's just one, but I shared.
Well, yes, definitely. One of the things that's super interesting, right? It not only is changing the standard of care, but changing what words mean, right? Abortion means something. You can't just decide as a bunch of folks sitting in a state capitol, that's no longer an abortion because we think that those should happen, and if we call them abortions, then they become bad. That's not how the world, I mean, it is how the world works, right? But it's this very, very strange thing. And again, this is not how medicine happens. It's how abortion happens.
This point that you're making kind of goes to my next question. What if the doctors are providing bad guidance? Like you've talked, the lawyers. You've talked to a bunch of lawyers saying, yeah, we want care to happen. We want it to happen within the law. But what if their interpretation of the law draws the line in a way that not everyone would agree with? Because I winced at some of the stories you were telling Dr. Mardy. I was like, well, that's not what I think the law is, right? So you're getting guidance from your hospital lawyers that other lawyers might say, well, that's not exactly all that's required, or that's too conservative. Like,
yep.
What do we do about that?
Yeah, I mean, I think that that's a huge, huge problem. And it's one of the reasons why I wish that people were talking to each other more in the same state, right? Because if we can all get on the same page, it's sort of helpful for us. I wish that professional organizations were doing a better job of talking to these lawyers and giving them guidance as a group, right? And letting people talk to each other. I also think, though, that, as I said before, I haven't talked to anybody who was like, thank God that we changed the law and now we don't have to do abortions here. But I'm sure that there are people like that. And, lots of lawyers are conservative people. I don't mean that politically, right? I mean, they're about, let's be as safe as we can, particularly when you work for a hospital, because some of the things that the fears that people raise, you're a public hospital, if we do abortions that the legislature doesn't like, are they going to yank money from us next time they're doing appropriations, right? I mean, people have valid concerns here, and those are the kinds of concerns that would lead you to say, let's do what we absolutely have to do, but nothing more. We don't want to get up to the edge of what might be acceptable. And I understand why people might take that position, because they feel like, I work for the hospital. My job is to protect the hospital, as well as the people in the hospital and the patients in the hospital. But my job is to protect the hospital. And the best way that we do that is to be as cautious as possible.
Okay, thank you all for coming. I think we'll leave it by, let's have a big round of applause.